Hello and welcome to the Cincinnati Heart Failure Lecture Series, covering the basics. We're going to be discussing congestive heart failure. This is the part 2. My name is Mahir Poriyahi, and thank you for joining us. In this lecture, we'll cover pharmacologic interventions, medications, and how they help. When we look at renin-angiotensin-aldosterone system, almost at every step of this setup, we've attempted to intervene, with majority of them leading to a success, not necessarily all of them. And we'll cover some of the medications that then fall within this that are going to make a difference in morbidity and mortality. So landmark randomized controlled trials that assessed ACE inhibitors or angiotensin converting enzyme inhibitors are mentioned, consensus being one of the most important ones, solved close second to follow. Angiotensin converting enzyme inhibitors, method of action, proposed mechanism includes reduction in sympathetic activity, endothelial dysfunction, sodium retention, and vasoconstriction. Blocks production of angiotensin 2, decreases sympathetic stimulation, decreases production of aldosterone and vasopressin, and decreases vasoconstriction. This also increases bradykinin, blocking their metabolism, increases vasodilatory prostaglandins, delays and prevents myocardial remodeling. The benefits is a decrease in mortality, 25 to 50% relative risk reduction, decrease in hospitalizations, symptom improvement, and clinical status improvement. Cough is probably one of the more common side effects of ACE inhibitors. It's contraindicated during pregnancy, bilateral renal artery stenosis, and or renal insufficiency and hyperkalemia. Angiotensin receptor blockers. The Valiant study compared valsartan to captopril, demonstrating equivalent benefits in terms of morbidity and mortality. Entresto, or sacubitril valsartan, is a neprilysin inhibitor and angiotensin converting receptor blockers. Neprilysin inhibitors impede natural endopeptidase activity on breakdown of natriuretic peptides. Neprilysin inhibitors and an ACE are associated with increased risk of angioedema. Paradigm HF found statistically significant reduction in primary endpoints of cardiovascular death or first hospitalization or for worsening heart failure and death from any cause. So this is kind of the both modality of where it's working and how it's affecting the system. I think this is a pretty decent diagram. What's interesting to note is a number needed to treat of 21. Beta blockers are another one of our major pillars in heart failure management. Method of action is selective inhibitor of beta-1 adrenergic receptors, competitively blocks beta-1 receptors with little or no effect on beta-2 receptors. This is seen in metoprolol. Non-selective beta-adrenose receptors and alpha-adrenergic blocking activity in carvedilol. And then selective inhibition of beta-1 adrenergic receptors, competitively blocking beta-1 receptors with little or no effect on beta-2, seen in bisoprolol. Below, you can also see some of the initial dosing and max dosing of some of these medications. Realize that beta blocker effect is not a class effect, and it's only with certain selective beta blockers that have been shown to decrease morbidity and mortality in heart failure. What about the studies? There are plenty of studies assessing utilization of beta blockers in heart failure. Merit HF, Copernicus are some of the more important studies to outline, but all of these studies led to our current understanding of how to manage heart failure. Benefits is reduced risk of death, reduced hospitalizations, may not improve symptoms initially. Patients may require more diuretics. In new onset heart failure, do not initiate beta blockers until patient is euvolemic or near euvolemic state. Adverse events equals bradycardia, worsening heart failure. What about metoprolol versus carvedilol? The age-old question. The COMET trial assessed metoprolol tartrate versus carvedilol. Compared carvedilol to metoprolol tartrate short-acting form, utilizing the target doses that are mentioned. They examined 14,000 patients in Norwegian heart failure registry. No conclusive association between all-cause mortality and treatment with carvedilol or metoprolol succinate. What about aldosterone antagonists? Method of action is selective blockade of mineralocorticoid receptors, decreasing blood pressure in dose-dependent manner, and appears to prevent myocardial vascular fibrosis. The 3 critical trials are mentioned, and the criteria at which they utilize these drugs. Aldosterone blockade led to improved outcomes in morbidity and mortality, 30% reduction in all-cause mortality. The utilization in GFRs less than 30 or potassium above 5 is not recommended. Again, those trials that we mentioned previously. SGLT2 inhibitors, their method of action is inhibiting sodium glucose cotransporter 2 in the proximal renal tubule, which reduces reabsorption of filtered glucose from tubular lumen. SGLT2 is the main site of filtered glucose reabsorption, so it reduces plasma glucose concentration. Empagliflozin also reduces sodium reabsorption and increases delivery of sodium to the distal tubule, which may lower both pre and after load of the heart and deregulate sympathetic activity. This chart is slightly outdated, but these are some of the more important SGLT2 inhibitor trials. There are new players to this list. With some of the overall heart failure hospitalization and cardiovascular mortality, which was the combined goal, what I would mention is the robustness of the data is not that great. However, it does drive a lot of improvement in symptom profile and overall exercise tolerance and hospitalization. What about hydralazine and isosorbide, seen in BIDO? Hydralazine is a direct vasodilation of arterioles, resulting in decreased systemic resistance. Isosorbide, stimulation of intracellular cyclic GMP, resulting in vascular smooth muscle relaxation of both arterial and venous vasculature. Reducing cardiac oxygen demand by decreasing preload may modestly reduce afterload. And coronary artery dilation improves collateral flow to the ischemic region of the heart. VHEFT, which compared BIDO to placebo, showed 43% mortality reduction compared to the placebo. This has been shown in Black patients with heart failure. What's the role of funny channel, and why do we care so much about heart rate? We know that a heart rate more than 70 beats per minute, every 10 increase from that is associated with higher mortality. Ivabradine is considered for use in stable euvolemic patients with sinus rhythm with resting heart rates above 70 who are already on maximum tolerated dose of beta blockers. Contraindication includes arrhythmias. What about soluble guanylate cyclase stimulator such as vericiguat? It enhances production of cyclic guanosine monophosphate by directly stimulating soluble guanylate cyclase independent of nitric oxide and enhances sensitivity to endogenous nitrates, thereby increasing cyclic GMP production. And this leads to the overall smooth muscle relaxation and vasodilation. Victoria trial looked at this. So further trial-based specific endpoints. What about the medication use patterns? Even though we have all these options available, we're not really good at starting patients on appropriate therapy pretty rapidly. So what are some of the recommendations for heart failure management? For stage A is consideration of SGLT2 inhibitors, optimal blood pressure control, overall risk reduction, and genetic screening if appropriate. For stage B, ACE inhibitors where appropriate, ARBs if not tolerating ACE, beta blockers, ICDs. And finally, with heart failure with reduced stage C, mix of all the drugs that we currently talked about, plus or minus Bidal or hydrazine nitrates in African American patients, ICD consideration in patients with ejection fraction less than 35% with NYHA class 1, 2, 3 symptoms, CRTD in patients with left bundle branch block, and in patients with refractory heart failure stage D, considering heart failure consultation, advanced heart failure workups, and advanced therapies. How should we sequence treatments? The McMary group actually did a really good conversation, started the conversation about how aggressive we should be. Conventional methods required weeks, if not months, of titration of medications. And with the current suggested method is in hospital, considering initiation of 2 of the pillars, with a consideration of a third agent on or around discharge, and a quick up-titration and adding of the 4 pillars, and a quick post-hospital follow-ups. What about the overall number needed to treat? This is a great slide that looks at all the agents and the overall number needed to treat, and I think this is really critical for us to understand. We've kind of hit up on this subject. This all should serve as a review. What about HFpEF, or heart failure with preserved ejection fraction? SGLT2 inhibitors play a great role. Loop diuretics can be considered, MRAs can be considered, and so is ARNI in specific patient subtypes. So it's important for us to look at drugs to avoid and what causes harm. So routine vitamins and nutritional supplements where it's not needed for the specific deficiencies shows no benefit. Non-dihydropyridine calcium channel blockers are not recommended as it can increase harm in heart failure. So are some of the antiarrhythmic medications such as dronedarone that can increase harm and mortality. Some of your diabetic agents can also increase harms, as can be seen. So TZDs and DPP4s. Routine use of NSAIDs can lead to worsening heart failure, and as such should be avoided. What about device recommendations? So in any patient with an EF of less than 30%, NYHA class 1 to 3, it's recommended. With patients with less than 35%, NYHA class 2 to 3 is recommended. CRT, it can be very helpful, especially in patients with left bundle branch block. You can see some of the 2A level recommendations here. How about non-pharmacologic? Diet, access to care, exercise can all play a good factor in better helping our patients. Exercise for heart failure patients is recommended. Seattle heart failure model can help better risk stratify patients and sometimes actually show them what each medication will do to their overall survival. Thank you guys for joining us in this lecture. Hopefully, by now you have an excellent foundation to overall heart failure management.